शुभ नाम जाए, तब शुभ आशीष मांगे।
थोड़ा लेफ्ट लो आगे।
गाहे तब जय गाथा, भारत भाग्य विधाता। जय हे, जय हे, जय हे, जय 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 हे।
Thank you. Foresight and business ethics. Good morning, ladies and gentlemen. A very warm welcome to the Golden Aims Conference and Award for Excellency and Leadership. It is indeed my pleasure and my privilege to be a part of this December gathering of top professionals and industrial captains. May I have your hands, please? You're shaping the Indian globe story with your inspirational leadership and entrepreneurial success. We are honored to have you all with us this morning. This has indeed been a remarkable journey, and to set the tone for this day, let me invite Dr. Farheen Khan, co-founder of CFO Golden Aims Brand Ambassador, Asia GCC. Also, may I have Azhar Farooqi, CEO and co-founder, Dynamic Business Solution. Thank you. Also, may I have on stage Dr. Manoj Gandhi, Director of Dr. Gandhi Nursing Home Private Limited, Secretary Bombay Nursing Home Association. Also have Dr. Sharma on stage, please. Sanjay Sharma. And Dr. Tanveer Abdul Majid, please. Thank you. Thank you. In the midst of so much destruction around us, of the market of sign professional industries, how about a destructive side of leadership, one that shakes things up, get the best out of the team, and yes, gets the work done? Perhaps that's the call of the day in an environment of rapid change. The leaders of Golden Aims Conference and Award for Excellence and Leadership command authority as well as respect, and yet we flatter organization structures and decentralization of decision making and empowering their team. May I now invite Dr. Farheen to say a few words. Thank you.
Good morning, everyone. I'm excited to share this morning with these dignitaries present here today. I, Dr. Farheen Khan, co-founder and CFO, Golden Aim, and Chairperson Asia GCC. Welcome you all to the 10th edition of Golden Aim Conference and Award. I would like to take this opportunity to extend the warm welcome to all the participants, the speakers, and other guests for gracing this occasion. Depending on the theme today, innovations, and digital era. Life would be so different if all our different dream comes true. Life would be so different if everything we did with a spirit, hope, passion, and achievement, and with a selfless determination to make things happen today. The digitalization is considered the third industrial revolution or the digital renovation, which began in the 20th century. Now we are shifting towards the digital era where everything is turned digitalized. The applications of digital technologies which are being forwarded to each and every industries. In every aspect of human life, moreover, today a very rare point out any sectors which are outreach of any kind of digital technologies. After noticing the importance of digital technologies in our daily life, we can say that digitalization has come to the hour. The live example is the corona pandemic. The battle with the various virus has been possible only because of digitalization. However, the era of digitalization is bringing a promising future to our world. I would not take much of your time and end this beautiful quote. Transferring is not the technology, it's the technology that is transforming you. Thank you everyone and welcome you all once again.
A very pleasant morning to all of you, and a very warm welcome to this 10th edition of Golden M Conference and Award. Firstly, I would like to extend my note of thank you to everyone for becoming a part of this event and gracing it. I, Mohammad Azharuddin Farooqi, the CEO and co-founder of Dynamic Business Solutions and the Managing Director of the Pharma Global Management Services. My company, Dynamic Business Solutions, we provide solutions in various segments and sectors, such as we are in the manufacturing industries, we are in the healthcare manufacturing industries, and we have the fitness academies, and we started the electronic business also. We provided end-to-end management solutions. We started our business in 2004 with a small warehouse in Mumbai, and with the team support, we built our business to national to international level. We have nationally, we have the chain in the Mumbai, Pune, Delhi, Bengaluru, and West Bengal. And internationally, we are in Dubai, Oman, and Indonesia. And I hope to build more chain in future. And very thank you to the Golden Aim team to give us a chance to be a partner of this the event. And the platform where the professionals and the thought leaders share their views and the knowledge. Thank you so much and congratulations to all of them. Thank you.
So actually I'm from Pune and presently I'm president of Indian Medical Association Pune branch. And this topic is a favorite topic of mine. And I was very glad when I got this invitation of speaking for digital health promotion. And this will go a lot for increasing the availability of our consultants. It will be increasing the consulting of practice of many people for the benefit of the patients. And it will be useful for all those people who are not able to reach and clinic. Hello, can you hear?
Yes, ma'am. Yes, ma'am.
Okay. Can you see my screen because I cannot see? Yes, okay. Okay. So, as per the head of Maryland Clinic, USA, Dr. Farhim Yunus had told us to live with COVID-19 for months or years. And let us not deny it, let us not be panicky, and let us learn to live with the situations. So now, with this practice, which was already like a daily work, if you can see on this Happy Doctors Day, this cartoon was going around so many times that now the doctors are facing attacks they are facing the inflation, they are facing illogical medico-legal cases. So along with this, now we have to face corona pandemic, HIV pandemics also had just gone, and TB pandemic is again coming up. And along with this, what we feel is that inability of a person to travel long distances or inability of a person to attend to somebody, to take him to a doctor, is becoming more and more rare and difficult nowadays. So telemedicine was started from about February 2020, when our seniors recognized the need of telemedicine. And it has been permitted by Medical Council of India from February 2020 or March 2020. So remember, when we say hello and we pick up the phone, it is starting with a girl's name. So it was a initial beginning of Margaret Hello, who was a girlfriend of Graham Bell, who invented telephone. And the first word on his phone after his invention was hello. And that is how we started talking with hello. And that is how we got now into a telemedicine, which is medicine from a distance, a remote medicine. What are the advantages of telemedicine? If you can see from this slide, you can understand that how the patient is having a changing lifestyle. Patient has accepted the disease, but there is a problems in management. So we have a telemedicine which gives you a higher quality of life because it gives you a disease management remotely, reduced periods of hospitalization, transparency of costs and services. There will be lower, not medication cost, but a supervision cost. And this will give rise to a higher efficient management of a disease of a patient, especially by a physician, and to the benefit of the patient, to the benefit of the caregivers, to the benefit of the caregivers who are there with the patient, staying with the patient. So doctors need a clear set of do's and don'ts, as they are accountable to provide teleconsultation as per the telemedicine practice guidelines. This constitutes the Appendix 5 of the Indian Medical Council Professional Conduct, Etiquette and Ethics Regulation Act 2002. A violation of the telemedicine guidelines will give the patient's avenue to complaint against the doctor before the appropriate state medical council for misconduct. So doctors have to have a knowledge of do's and don'ts. These guidelines were prepared in partnership with Niti Aayog, and they were introduced as amendment to the Indian Medical Council Act that gave a statutory support and basis for the practice of telemedical medicine in India. That means these guidelines are the correct guidelines and you need to follow them word by word. So what is the proper definition of telemedicine? Telemedicine is defined as a delivery of healthcare services where distance is a critical factor, whereby all healthcare professionals, they can use the technology, the information for the exchange of valid information for diagnosis, treatment and prevention of disease and injuries, plus research and education, and also for the continuing education of healthcare providers, all in the interest of the advancing the health of individuals and their communities. So who can do a telemedicine consultation? A RMP, that is a registered medical practitioner, MBBS and above, under the Indian Medical Council Act 1956, is a person who is enrolled in the State Medical Register or the Indian Medical Register under the IMC Act 1956. So whoever is enrolled in the State Medical Register as an RMP can do a telemedical consultation, or a National Medical Commission Act 2019, when it comes into full force and replaces it. So guidelines given according to that guideline, if they come, then those can be authorized persons for giving telemedical consultation. What are the authorized methods? Authorized methods is via any medium such as video, audio, text, WhatsApp, mobile, computer applications like Skype, Google Hangouts, etc. And modalities. Who can give to whom? That is, a patient can, you can give, RMP can give to a patient. RMP can give to a caregiver, or RMP can give to a healthcare provider, or RMP can give a telemedicine consultation to a different RMP on the other side of the other side of the area. So what should be the guiding principle for all telemedical consultation? Is a registered medical practitioner is well positioned to decide where a technology-based consultation is sufficient or in-person review is needed. And this is most important, that the registered medical practitioner himself or herself can decide whether the complaints of the patient can be connected or can be properly counseled, communicated by a online consultation or by an in-person review. So the decision should be of the doctor. The practitioner shall exercise proper discretion and not compromise on the quality of care. And 7 elements need to be considered before beginning any telemedical consultation. First is the context, that is the context of the complaints. Secondly is the identification. So the doctor and the patient should identify themselves online in the recording. Then the mode of communication should be identified. Consent should be properly documented. Type of consultation should be decided upon. Then the patient evaluation, and then the patient management. So the context, the first thing is the context. So how the context should be there, it should be appropriate and sufficient. The doctor should be able to provide telemedicine consultation by adequately prescribing medicines, by providing counseling like food restrictions, do's and don'ts for anti-cancer drugs, proper use of a hearing aid, etc. And doctor should be able to impart health education, that is the counseling regarding advice on contagious infections, immunizations, exercises, hygiene practices, mosquito control, etc. The second is that the identification factor should be clearly defined. Especially for the first consultation, patient identification is mandatory. So patient himself or herself should say out that I am so and so, my age is so and so, I am living in this area, and the disease of that person should be called on. If a caregiver is speaking on behalf of a patient, then caregiver identity and authorization should also be checked. Doctor himself or herself should identify to the patient before the start of each consultation, and the registration number at every touch point with the patient should be emphasized. Mode of communications is via any medium. The doctor can choose a suitable medium of teleconsultation. Like I told you before, it can be an internet, it can be a mobile app, it can be chat platform, or it can be a Skype, email. So decision should be taken by doctor as per case-to-case basis. Patient is responsible for the accuracy of the information which the patient is giving. That is what I told you in the previous slide, that whatever the patient is giving you information, you are going to act on that. You are going to counsel on that. And that responsibility of that information is the responsibility of the patient. So know the limitations of the various modes of consultation. In the video consultation, it can come closest to an in-person consult with an inspection, which depends upon the high quality internet connection at both the ends. And it also should ensure privacy of the patients in the video consultation, which is very important. Then in only audio consultation, it is convenient, fast, it has got an easy reach, but non-verbal cues may be missed, and it may not be suitable for conditions that require a visual inspection. And sometimes there is a text-based consultation in which questions are asked and answers are given. So in these, the visual and the verbal cues most may be missed, and it may be difficult to establish rapport and a proper communication with the patient. The fourth aspect is the consent of the patient. Consent of the patient is implied when the patient initiates consultation, but it should be explicit when a doctor starts a consultation. So when a doctor starts with a consultation first, the consent of the patient should be taken in an explicit manner. A healthcare worker, RMP, or a caregiver when he or she initiates a telemedical consultation, it should be recorded in any form, either in a chat box or in a paper, and then the paper should be shown, or otherwise it can be explicitly told or expressed out while consultation. First consult means the patient is consulting with the RMP for the first time. The second consultation means if the patient is consulting after 6 months of the first consultation, will count as second consultation. Or if the patient consults within 6 months of the first consultation, it will be called as a follow-up consultation. So a patient consulting with the same RMP within 6 months of a previous in-person consultation will be a follow-up consultation. Remember, it will not be considered as a follow-up if there are new symptoms that are not in the spectrum of the previous treatment. Not only the RMP, even if the patient doesn't recall the context of the previous treatment and advice, then also it will be taken as a new consultation. So any new symptoms, new areas of coverage, and new complaints of the patient will be taken as a second new consultation. How about patient evaluation? Exchange of information for patient evaluation should be adequate. If the doctor is not convinced with the information at hand to make a professional decision, he may ask the patient to change the mode of consultation and provide such documents or undertake such tests as required. RMP shall maintain all the patient records, including case history, inverse images, etc., as appropriate. Caregiver is deemed to be authorized on behalf of minor or incapacitated patients. In such cases, the teleconsultation can take place with the caregiver without the presence of the patient. Doctor is not to continue with teleconsultation if it is not appropriate or not satisfied. Patient's personal data should not be disclosed or transferred without the legal and written consent of the patient. Doctor should not deny in emergency teleconsultation, but it should be limited to immediate assistance or first aid only. And the doctor should know the limitations of prescriptions of medicines. How can the emergency consultation be given? The telemedicine services should be avoided for emergency care whenever alternative in-person or actual personal care is available. Telemedicine consultation should be limited to first aid, life-saving measures, counseling, and an advice for proper referral. In all cases of emergency, the patient must be advised for an in-person interaction with an registered medical practitioner at the earliest. So it will be only emergency management guidelines and a counseling as to how the patient should go forwards or to go to which area, which hospital, which doctor for the next immediate treatment. In order to prevent abuse, remember that the telemedicine guidelines require every doctor to prescribe medicines via telemedicine only when the doctor is satisfied that she has gathered adequate information and relevant information about the patient's medical condition and the prescribed interests are in the best interest of the patient. Prescribing medicines without an appropriate diagnosis can amount to professional misconduct. So unless you can gather a full idea of the patient from the relevant data which he has provided and from your online checkup, then only you can prescribe a proper medicine. How can you prescribe a medical or give a prescription? Online. So online, on the letterhead with an MMC registration number, first of all, the provisional diagnosis should be mentioned. After that, the RMP shall photo scan digital copy of the signed prescription to the patient via email after writing the prescription, of course. So first is you should write it is your MMC number, your name, your MMC number, your telephone numbers. Then the diagnosis should be mentioned. And then the prescription, after writing it in proper handwriting, it should be scanned. And the digital copy should be sent via email or messaging platform to the patient. If the transmitting the prescription directly to a pharmacy, the person should ensure explicit consent of the patient that entitles him to get the medicines dispensed from any pharmacy of her choice. Also should give a receipt or an invoice for the fee which is charged. to the patient so that the patient keeps the bill of it. As a thumb rule, as an important thing is you should remember as a thumb rule, prescribing medicines for chronic diseases should be avoided for long term during teleconsultations unless it's an add-on or refill of the earlier prescription obtained during an in-person consultation less than 6 months back. If a prescription for chronic diseases is to be insured, then the video consultation should be done strictly via video because chronic diseases require a video consultation to assess the improvement or the deterioration. If the teleconsultation with the patient does not take place over a video, doctor can only prescribe over-the-counter medicines like paracetamol, ORS or cough lozenges or cough medicines also you can prescribe. Add-on medication where the in-person consultation was less than 6 months ago, and a few emergency medications, even if they are not OTC medications, as and when notified by the government. So few medicines can be prescribed even if an online video consultation does not occur or cannot take place. Only remember few things that emergency contraceptives can be prescribed on phone or by telemedicine, but medical termination of pregnancy pills can never be prescribed by online method. Patient has to go physically to the nearest center because it is not an emergency. You can go within the requisite amount, that is amount of days, that is first trimester can be done within 9 weeks or 12 weeks of pregnancy, second trimester between 12 to 16 or 20 weeks of pregnancy. So this is the table which shows a scope or the limitation of the prescription. If a prior in-person consultation is not done, then a RMP can prescribe only OTC medication like paracetamol, ORS, antacids, cannot prescribe medication for which diagnosis is possible only by video consultation like antifungal medicines like eye medicines, cannot prescribe add-on medication, cannot prescribe refill medication, and cannot prescribe habit-forming or narcotic or psychotropic drugs. If a prior consultation in person, it is physical consultation for the same health condition has been done in the prior 6 months, then a follow-up consultation which is done in the next within 6 months, then you can prescribe an OTC medication. One can prescribe an add-on medication which are used to optimize an already existing and stabilized disease. Like you can add one more antihypertensive, or you can add one more anti-diabetic medicine. Then one cannot prescribe medication for which diagnosis by video consultation is done. That is there. Cannot prescribe refill medications and cannot prescribe habit-forming medications for video consultation is not done. So what are the exclusions in guidelines? Is there specification for hardware, software, infrastructure, building and maintenance? Data maintaining management systems are to be involved and standards and interoperability measures to be taken. Use of digital technology to conduct surgical or invasive procedures remotely. Other aspects of telehealth such as research and evaluation and continuing education of healthcare workers does not provide for consultations outside the jurisdiction of India. So these are the exclusions in the guidelines. This is the medico-legal advisory, which is now shows that telemedical consultations are now covered under the health insurance. And there are guidelines from IRDIA saying that telemedical consultations with a medical practitioner allowed done in proper guidelines and in terms and conditions of a policy contract can be a part of claim settlement of policy of insurers. So patients will now be able to get health insurance benefits even if they consult doctors or hospitals using telemedicine. So thank you all for patient hearing and all the best for litigation-free practice and a healthy yourself for you. So thank you.
I apologize for the video. I know it was small, but I'm glad that the message was conveyed beautifully. Thank you for your patience. And now we can quickly start the awards. May I have on stage Dr. Farheen Khan and Azhar Faruqi to present the awards, please. May we first have Dr. Sanjay Sharma, Director, Professor Oncosurgery, Asian Cancer Institute. May we hear for him, please. Come on, people, we have your turns as well. Thank you, Dr. Sharma.
Good to see you.
Now, may we have Dr. Ramakant Deshpande, Chairman, Asian Cancer Institute, ACI Kumbala Health Hospital, Kem's Corner, Mumbai.
I'll take the one. He's not there.
Okay.
He's in the flight. He will be on the line.
All right, he's still traveling. Thank you.
We'll thank the Digital Solutions, the Golden Award group, Dr. Fardeen and Dr. Faruqi, to have given this honor to us. In fact, I remember that this is the third time that we have got it. And this award for me and Dr. Deshpande is an award for the Asian Cancer Institute group. We are all ex-startup group. My colleague, Dr. Tanveer, is also around. Dr. Gandhi is a colleague. He's been worked with us in Tata Memorial. So all of us are now outside Tata Hospital after we have completed our 10 years at Tata. And now we're trying to give the same facilities that were probably too much of rush in Tata Hospital at different places in all. And we have now 4 centers, 2 in Mumbai, 1 in Indore and 1 in Bhubaneswar, and hopefully we have more institutions. And you will be happy to know that Asian Cancer Institute is totally digital. Everything is digital, including the consultation if required is digital, and all the things are recorded. Nothing is written, handwritten, but everything is digital. So I must thank the organization to have this award to me and Dr. Deshpande, my colleague, and I thank you all for have a good journey in future for growth of Golden Group in different spheres. Thank you very much.
May we have Dr. Tanveer Abdul Majid, Cancer Surgeon, Kokila Pain Dhirubhai Ambani Hospital, Navi Mumbai, Zen Multi-Speciality Hospital, Mumbai, and Asian Cancer Institute, Mumbai.
This award is dedicated to my teacher Sanjay Sharma sir and Dr. Deshpande. Without them, I was nothing. They taught me everything of oncology, and this is what I am here today because of them. Thank you, sir, so much.
Thank you. And now we have the Dilka Doctor, Dr. G.P. Ratna Parkhi, Consultant Interventional Cardiologist, Guru Kripa Healthcare Center. This is an outstanding contribution in field of healthcare cardiologist.
Sir.
All right, and now the iconic Healthcare Leadership Award neurosurgeon, Dr. Mohnish Bhajiwale, neurological surgeon and managing trustee of Neuro Health Foundation Clinic. May we have you on stage, sir.
बहुत शुक्रिया. I really want to thank the organization, Golden Aim Award organization, for giving me this award, mainly because the Neuro Health Foundation actually stands for the importance of the brain today. So many decades have gone concentrating on other organs of the body, but today we see that diseases of the brain are really increasing in tens of thousands. COVID actually brought about an acceleration now. Many may not be knowing, but the fatigue which COVID has caused, the fatigue actually is resulting in a lot of migraine headaches and as a consequence, even strokes. Another factor which I'd just like to quickly highlight is the impact of global climate change on the diseases of the brain. And today, as you can see, what the newspaper today is saying, this is winter going on or summer is a question to everybody. So such climatic changes have a direct impact on the brain circulation. And Neuro Health Foundation, our organization which is working since 2009 and has treated more than 1 lakh patients here in Mumbai itself, concentrates on these two very important aspects. Another aspect we look at is a neglected aspect, public hospitals and medical teaching. And we feel that all as we move and become greater doctors and big names, I feel that we all have a responsibility to look back and see what difficulties we faced as young doctors. One, mainly because public hospitals still are quite a mainstay of healthcare for poor people. So on that note, I'd like to again thank the organizers and thank you again for highlighting the importance of brain in the coming times. Thank you very much.
Thank you very much, Doctor. May we have our next speaker, Dr. Manoj Gandhi, Director, Dr. Gandhi Nursing Home Private Limited, Secretary, Bombay Nursing Home Associations. And the topic for him today is health insurance, very important for us.
Good morning, everybody. I would like to first thank the organizers to invite me for this very important topic of health insurance. I would first like to know as to how many people are there from the insurance sector in the audience today. From the health, is there anybody from the insurance company side today? No. And how many people are there from the healthcare provider side, like from the hospital side, who are dealing day in and day out with the cashless? Can I have the raise of hands? So now I have been there working in smaller hospital. I've got my own hospital. I've been working in corporate hospitals. I've been working in cooperative hospitals, and I've seen work patterns in government hospitals also. Health insurance is a type of insurance offered by the government or private insurance companies that covers healthcare expenses incurred by policyholders for necessary. This is a basic, outline of what healthcare insurance is. And it is obviously the most important and critical planning for the individual. It is a contract between the insurer and insured, wherein the former agrees to pay to the latter hospitalization expenses to the extent of the agreed sum assured in the event of any medical treatment out of an illness or it. Where does the role of the hospital comes over here? This is just a contract between the insurer and the insured. insurance company and the insured. Actually, the hospital is the main player over here, but 99% of the times, the hospital who gives the credit to the insurance company for serving their customers as patients are bulldozed by these insurance companies, especially the small healthcare providers. I am the secretary of around 700 nursing homes across here in association having called as Bombay Nursing Home Association, which has seen all the patterns of changes of the working patterns of most of the insurance companies and TPAs. So, in a layman language, the health insurance is a policy which covers you and your family against medical expenses due to sickness, accident. The insured in return has to pay. So, for the doctor or the hospital, the payment, whether it comes from the patient, if he goes for his reimbursement or direct payment or a cash payment, or whether it comes from the insured, it doesn't make a difference. The hospital has to sustain. If it has to give quality service with infrastructure upgradation, there has been a huge change post-COVID in the infrastructure requirement of the majority of the hospitals, whether it is a small hospital or a larger hospital. Obviously, even if the hospital doesn't do profit, to provide quality health care, to provide sustainable health care, to provide sustainable infrastructure, there has to be some remuneration flowing to the hospital. It's not a question of only growth of the hospital. Obviously, with growth, the infrastructure requirement, technological requirement, upgradation of the medical equipment, but there's a definitely continuous running cost going on for the hospitals, which needs to be maintained. So definitely everybody knows that the cost of healthcare is rising. The government is behind us to reduce the healthcare, but with technological upgradation, it is very, very difficult to reduce the healthcare. It can be reduced and made sustainable if we all work in a synergistic manner. The health insurance decision is not whether to obtain it, but which health plan to purchase and how much coverage to purchase. Now, many of the times, we always have that trademark statement on all the advertisements, read the minor document, minor lines and but many a times, who has the time? You tell me which of you all in the audience have actually read the first page to the last page of the insurance policy. I'm sure none of us. I have not read. So there are many things written in those documents where the education has to be passed on by the insurance agent or the insurance company to the customer or the corporate who are insuring their employees. So options for purchasing health insurance. There are two types basically, a corporate insurance and individual insurance policy. And then there are government sponsored schemes like the Ayushman Bharat and other states having their individual insurance policies for their population. The self-employed individuals must obviously pay the entire cost of the health insurance. In case of the corporate or the government-sponsored insurance company, it is either the government who's paying it or it is the corporate company that pays it for the employee. It may be deducted in some form or the other from the employee's salary, but ultimately it is the corporate who initiates the payment. Health insurance again is offered by insurance that covers healthcare incurred by policyholders for the necessary medical care. And it's a critical component. Group health insurance. As I told you, many employers offer health insurance as part of benefit package to the corporate and the group employees. Here the major problem that occurs is that the employees are only told that they have got a Mediclaim policy as a part of benefit of their employment contract. But there are a lot of restrictions depending on the grade of the employee, class of the employee, whether he's an A grade, B grade, C grade or D grade employee, depending on whatever level his employment contract is there. So some of them will have, restrictions in the charges, some of them will have restriction in bed charges. Ultimately, those are not disclosed or majority of the times not disclosed till the patient comes for admission. Or he is not even aware of it, okay, these are the restrictions. That creates a lot of hassle for the providers, because when the employee comes, his understanding is that everything is covered. by my corporate company. But when he actually comes at the hospital and when the initial approval comes, that is the time when we come to know that these are the restrictions. And then a lot of play around happens by some of the patient that we want to adjust here and there. This doesn't cause a smooth flow of events right from initial admission to the final discharge. So if we have to have a smooth journey of a patient for cashless work or cashless medical treatment, then I think all corporates should disclose these individual small restrictions that are there to the employees in some form or the other when they come for admission. So the journey becomes easy, and the hospitals also know that what is to be collected as extra if required, not required, depending on the final approvals. I advise all the corporates to actually, or the employees of any corporate company where insurance is provided, to have a parallel individual policy. Because most of the individual policies of good companies do not have majority of the restrictions. So that they can get the proper benefit of the treatment wherever they go in whichever hospitals. And again, healthcare providers, it is called as managed healthcare plan, under which individual receives services from the specific doctors or hospitals that are part of the plan, or health maintenance organizations. This is a term coined by the government insurance companies like New India, Oriental, United and National. I don't know how many of you all are aware. It was initiated as a GIPSA group of companies. Here, the problem is that even if we want to work for them, they create a lot of problems for smaller hospitals. And there is a huge difference in how these people, do the tie-ups and process the claims. So if we do not bend down to their rules and regulations and restrictions, then they might not take the hospital on panel. Although this may be covering, I'm sure the government insurance companies are covering around 20 to 30% of the total insurance market in India. So, which if we have to cater to this group of people, there are many hospitals who are not catering to the GIPSA group of companies, which is a collection of the main 4 companies of government, that is the New India, Oriental, United and National. Plus, if we don't come to their terms to be on panel of those companies, then they try to tell us that we will not take you on panel to provide the cashless process, or we will want you to have a very reduced tariff for doing this. Now the hospital which is absolutely new or is not having footfalls, for them this may be important, but a hospital or a doctor who's having his own reputation, this may not be a criteria. All these patients are actually then reimbursed at their standard rates of the hospital. So I'm not saying that nobody should remove the government insurance companies, but then these are the problems that they may not get access for cashless treatment at all the hospitals wherever they want to go. So I put it as like this, that health insurance should be responsive, responsible and profitable. And who are the people who are responsible for it? So this is the entire chain. The who's are insurance companies and TPAs, individual patient and corporates, and doctor and the hospital. Without this, the entire game plan goes for a toss. Now, responsible means readily reacting or replying to a people or events or stimuli showing emotion. Now, in health insurance, emotions do not play a role. Because ultimately, when it comes to an insurance policy, it is a financial transaction. So, where does emotion plays a role when a doctor is treating the patient. But if you take the two aspects, whether it is the medical treatment and whether it is the financial commitment, both cannot be, associated with the emotional component. Responsive, submission of correct documents to the hospital, how early and whose responsibility. 90% of the time the patients will come to the hospital without their document. They will go to any other place, stand in a queue, submit the proper document. If a person goes to the bank, he will obviously take his bank, passbook, checkbook. If he goes for property registration, he will take all the required documents that are required for it pretty much in advance. But when he comes to the hospital, definitely half of the documents will not be there, his medical records will not be there. This is going on. We are trying to improve this. We are trying to educate the patients. At least at my hospital, we ask for all the documents in advance. So, digitally. In fact, COVID has taught us the digital revolution in everything. So, I just now heard Dr. Meenakshi from Pune saying that since March 2020, we have started teleconsultation and all. I've been doing teleconsultation since 7 years. So, it's nothing new that teleconsultation is actually there. It was always there. It's that COVID has given us a big boost, and everybody has taken advantage out of it. Even the health insurance companies have gone digital, have launched their portals, So, but these things do not change. Every time a person gives a call, whether to the hospital or to the insurance company, 90% of the answer is under process. Now, this under process in any call center doesn't have any meaning, because till the under process team gets their answers, it's a day elapsed in the treatment of the patient. Initial approvals, delays. There are some good companies who send, are very prompt in their replies to the hospitals. So it makes the hospital work also easy. They can concentrate on their medical treatment rather than doing, all this jugglery around getting the initial approvals, final approvals. So there are some insurance companies and TPAs who will give you initial approvals in 15 minutes, 20 minutes. Nowadays they have tag times for that also, and final approvals also. So the process has to be smooth. Nothing has to be delayed for the patient's admission, as well as for, if there is a rule where government is wanting that every emergency should be treated immediately at the hospital, we also as hospital providers would want all the processes to be smooth. Now, I want to lay something on this hidden facts by the patient, doctor and hospital. This is going to be always a grey zone where certain ailments, certain pre-existing disease, which are hidden by a lot of people. It is hidden by patients also, it is hidden by doctors also. It is sometimes overruled by the insurance company agents also. So, this is such a grey zone that it is very difficult to deal with it, but slow and steadily, I think all insurance companies as well as hospitals are coming around it, and obviously it should be mandatory that all pre-existing disease should be disclosed in all the medical records submitted by the hospital, which is obviously the most important document, but primarily it should be a protocol of the insurance agent who removes the policy. At that time all those things have to be disclosed, but 90% of the time today, or earlier also, everything happens on telephone, digital, and policies are automatically renewed or removed. So majority of the time at the inception only there is a problem. So if the policy initiation is going to be a problem, then eventual utilization is going to be even more problem. Obviously, in case of an individual patient, it is the responsibility of the patient to submit everything to the hospital. But most of the times, as I told you, they come with incomplete documents and agents. 90% of the time, they will not come with their papers properly. 90% of the times. And in case of corporate patients, I told you, they will just come and flash their card. This is my card, I want cashless. Which is not the correct. There's nothing mentioned on it. What is the copay? What is the restriction? Nothing mentioned on it. I've had a tough fight with most of the insurance companies. We at least want to know, just adding a small line of copay below the card is not going to take a lot of space in the corporate policy holders. So the hospital and the patient also knows at the time of admission only that this is the amount that whatever, suppose the bill is 50,000 and the copay is 10%, then hospital is supposed to collect that 5,000 rupees. Most of the time, this is wonderful thing, if it's a high profile top end client from a top HR company, then their cashless and insurance and everything is pretty smooth. I have had one very beautiful incident where a top executive from a top corporate company, his wife was just admitted in a top corporate hospital for a maternity delivery. And there were 30 employees from the insurance company sitting in the lobby of the corporate hospital just to see that everything goes on. Tell me whether they will do the same thing for a person from Jhopalpatti who will have a 5 lakh policy. They will not do that. Is his policy different from the policy of that high-end customer? No. HNI customer? No, it's the same. He should get the same benefit what others are getting. So my point is that if you have an insurance policy, everybody should get the same benefit. Again, these initial approvals, final approval, medical knowledge, this is the responsibility of not only the doctor but also the insurance company and the TPA. I recently had two very good incidences where from one insurance company I had an enteric fever with colitis patient admitted at my hospital, and they troubled me throughout the day with 7-8 queries. There was a non-medical team, medical team from the insurance company raising queries. Ultimately they did not give me the approval. I gave all the explanation why the approval should be there, what is enteric colitis, medical knowledge given to them by me. In spite of that, they did not approve. Ultimately, due to peer pressure from the insurance agent, due to peer pressure from whoever higher up authorities were there, they passed the claim in the reimbursement. I came to know about this and I told the insurance company, whoever I know in that insurance company, that this is not justifiable, because if it was passed in reimbursement, it should have been passed in cashless. It would have avoided the hassle for the patient and the hospital. Just a week ago also I had a similar one condition called as leptospira fever with acute radiculitis of the spine. Same thing, and I get a reply from the grievance officer, we will reply after 5 days, by the time the patient goes home. On the third day, an investigating officer comes. Obviously by third day the patient who is not able to walk or weak will be little better. So a non-medical person comes from this insurance company and tells me that he is better. Why have you admitted him? You could have treated him on OPD basis. So my point over here is we are not against as hospitals. We want to cooperate with you all, to work with you all, because we are the focal point around which everything rotates. Today if doctors or hospitals are not there, where will the insurance companies go? Everybody is trying to make a pie out of it. But then consider that hospitals and patients, we are the focal points. It's not the insurance company which is the focal point. Scrutiny by non-medical patients, majority of the time, they appoint 12th pass. They're just still continuing, BCom pass. Most of the insurance companies will have, I'm not against any pathy, but they will have homeopathic doctors or Ayurvedic doctors who will want to come and justify that this is not an admission which is required, which is not the case. They can't come and challenge a super specialist that this is not justifiable. I can tell you a story about 17 years ago when I had a patient of diabetes with hydrocele, and we had a particular package tied up with insurance company, which was just for 1 day's admission, and he had come with a sugar of 500. So I sent a request to the insurance company, okay, we will control the sugar, do the surgery. Controlling the sugar might take 2 days, do the surgery 1 day, and send him with controlled sugar back home. So it will be 4 days. So they did not agree to that. Your package is just for 1 day, why are you admitting for 4 days? I said fine. We will send the patient to your office, you will control the diabetes, we will operate, we will send back to the same day evening, I will send back to your office, and we will discharge the patient. You give us 1 day's package charges, we do have no problem with that. Ultimately they agreed for 4 days stay. So these small things now causes a lot of irritation to the healthcare providers who want to work with all the insurance companies. Now the same thing I was telling about the GIPSA group of companies. I don't want to say it openly, but the truth is that if we don't agree to their rates, or we don't agree to give them a pie out of something or an extra discount, they don't want to take the hospitals on panel. How do we treat those 30 to 40% of the patients who are insured with the government insurance companies? And then government wants us to work for them. How do we do that? We also, as doctors who are running the private health, I'm doing charity now. I'm doing 100 laparoscopic surgeries a year in my own village, totally free for patients. So we can't do charity at every level. When a patient is insured, the hospital or the doctor has to be assured charges which are justified as per the market scenario. Again, it's the same thing, standard billing patterns. We've been after a lot of insurance companies to, have everything standardized. But till date, you'll have, portals who are having various forms. We give them suggestions also, but their suggestions are always to be accepted and granted are always under process. I like this word, under process. In any corporate, if nothing is being done, the emails rotate around within the employees and the answer that the opposite party gets is under process. Now discounts also obviously at the total discretion of the hospital. The insurance companies cannot demand the discounts. If the hospital wants to give, but unless we tell them that we are giving this much amount of discount, they don't take the hospitals on panel. So there are a lot of small hospitals who are not doing these government insurance companies and GIPSA because of the same reason. Even major corporate hospitals who are facing troubles with them are not doing GIPSA work. Even private insurance companies where few are creating problems are not being processed, and treated. So you can't have that all insurance companies will be on panel of all the hospitals. That will be the ideal scenario, so the patient can have the right to go anywhere where he wants to his desired doctor, to his desired hospital. But that is not the ideal scenario. Obviously, health is important for everybody, and for the corporate, having a good healthy employee is benefit in terms of his medical health. Now, is it a profitable venture for insurance companies? Everybody assumes that it is not. But if it was not, then why would we have so many privatization of insurance companies? Even government is contemplating privatization of everything in insurance. There's going to be mergers of the PSUs. It is going to be merged with LIC also. So we don't know what is going to happen. But maybe budget 2023 and things may change again. So definitely there is a market for profitability. How they balance it is a different thing. There are different roles of play. They can balance it with their life insurance policies, or they can balance it with their premiums collected for medical policies, car insurance policies. So it's not that it's not profitable. They have to manage their claim ratio, which they can manage. It's not. And obviously their own infrastructure cost is high. You have 12 pass or the pass guy coming with a tie, sitting in an AC comfort, trying to process our claims. There will be 50 employees sitting in a call center of an insurance company in a comfortable environment, which is not the case of the nursing staff in the hospitals. They will not get that same benefit. But it is they who are, in fact, who has treated the patients during COVID? Can you all answer anybody? Who are the prime people responsible for treating the COVID patients? Is it the doctors? Is it the nursing staff? Is it the administrative staff? It is the BMC? Who is it? It is only the nursing staff. The IR, the sister and the ward boy who have gone closer to the patient, risking their own life. Tell me who is telling that they have done a great job. Nobody is telling. Majority of them are not telling. Okay, but it is they who have risked their lives, became COVID positive and treated us who were all COVID positive by coming closer to us. The doctor, majority of them, apart from ICU cares, majority of the other places where the doctors were on, calls or visits, they were sitting in their cabin and giving the instructions or doing telemedicine. I have done telemedicine for more than 150 patients in March 2020, in the first month of lockdown. So it's like that, that's the truth. So infrastructure software requires expenses which can come only from the premiums collected. So there is some profitability definitely. Claim ratio, as I told, is important for such profitable footfalls. For hospital, it will obviously be a profitable thing if we start taking cashless and insurance patients, because it can increase the footfalls. And for individual doctors running hospital, they need to make profits. It is a very simple calculation. When I had invested in my laparoscopic equipment way back in 2004, the cost was not more than 10 lakh. Today the cost of the same laparoscopic equipment with upgradation is 50, 60, 70, 80 lakh. So if I have to upgrade, there has to be some sustainability. Nobody wants a Mercedes on day one. Everybody can run around in Maruti, but Maruti also has to be sustainable. Now here what I'm saying is that this is my triangle of the entire healthcare scenario in India or internationally also. There is an insurance company, there is a patient and TPA. Ideally, the patient is the focal point around which everything rotates. But for me, it is the doctor and the hospital which is the focal point, because without their own existence, the insurance companies are nowhere. And it is the hospital which is giving the credit to the insurance company. It is not the insurance company who is giving the credit to the hospital. So this is the market scenario. These are some figures way back in 2000. I'll come to the 2022 figures also, but these were the figures around in 2015 about the market size of health insurance, which is all in terms of crores. And you can see the exponential growth. Total revenue forecast. This is all 2015. I have given this slides to just compare with the current scenario. So the 2022 slides are just. This is again my value chain. Who are responsible, what position they hold: IRDA, payers, intermediaries, providers, insurers, customers. And these are seekers and literacy rate and all basic data. I won't go into the details of this. Population ratio, age group. This is my 2022 ka scorecard. If you can see that the general insurance, which is the PSUs, their market premium collection and their growth rate, and you can see the standalone private insurance company where it is growing. Okay. And you can see the stakes insurance company wise also. Where do the government insurance companies stand, and where is the growth of the private insurance company? So slow and steadily everything is going to move towards private. How, whether it will be a public-private partnership or it will be totally private, it is difficult to analyze right now. Thank you.
Founder and Chief Nutritious Health Mantra, and may we have Dr. Fareed once again to honoring the most trusted weight loss and medical condition expert in Mumbai. David, she's an integrated marketing and communication planning expert, and the topic she will speak today is for integrated marketing and communication plans. Thank you.
Very good afternoon to everyone here. We really had a very educational talk when I was listening. I'm a non-medical part of a hospital. So this was a lot of knowledge that was shared today. So I would firstly thank all the speakers who really shared wonderful knowledge. So now what I'm going to talk is the part of every hospital's, rather every institution that is required as well. And that is communications. When I say communications, for me communications is not just one part of it. But if you see, during the COVID, we all understood one thing. Only one person cannot perform, be it giving a service or be it talking to the people. We couldn't say that, the best of the print media at those days were not performing. But if we saw digital, like wow, everybody were like all over the digital, be it video consultations, be it your Facebook, be it the Facebook Lives. I mean, I myself have conducted almost 30 episodes I have moderated in Facebook Live for different doctors, the stalwarts in the industry. So, in the end, you see that there are many types of marketing that is a part of spreading awareness talking about your product, talking about your brand to the people. But they all need to be integrated. So that is the reason I've come up with the topic, integrated marketing communications. Why, when, and how. So firstly, I will speak about the types of marketing communications that we generally, most of us are using. First is the print media. So when I say print media, it is your newspapers, it is your TV channels, it is your radio channels, it is the big billboards. They also come with their own benefits. Now what are the benefits of a print media? I mean, most of you, a doctor, when he sees his article in the category A, like Times of India, he'll be like, oh, I was seen yesterday in the Times of India. So he's very happy about it. Why is he happy about it? Because the print media, the Cat A media, gives the boost to the brand. Secondly, it is attacking and seen by most of the mass audience. So it is not only one person who is going to see it, the newspaper is read by so many people. When a doctor has an interview in the health show of a TV channel, he's very happy about it. I see them promoting, on their Facebooks, on their Instas, and now there are so many reels, short clips are promoted. So again, if you see, they are integrating it. Third thing about the ATL or PR is it defines the brand standard. When you see a brand always publishing in the category A media, you say, oh wow, that's a big brand. Oh wow, we saw a full page ad of it. So you start perceiving that brand as a big brand. Be it healthcare, be it non-healthcare. That is the perception of the brand that is made by the people. The fourth is talent acquisitions. Now when I say talent acquisitions, what is it? When you're working in a company, I have been fortunate to work in one of the best healthcares, Asian Art Institute, Fortis Healthcare, IHH Healthcare, which today contributes to Fortis and global hospitals. Plus today I am with Just Look, one of the brand which has 50 years of legacy. So when we are there and we see, our doctors have spoken in this media, we've got the articles, so we feel very proud about our brand. So that is where you get good talents. So other hospitals talk to us, oh, we saw your doctor at this brand, what was that, what was the article all about? So it gives you even good talent acquisition. So this is all about ATL, this is all about the media which is expensive as well. So moving on to the next type of marketing. Digital media. Favorite, liked by everyone. I'm sure all of us are on Facebook. Anybody who's not on Facebook can raise your hand. Oh, there's one. So anybody who's not on Insta? Okay. Anybody who's not on LinkedIn? So if you see, the majority of us are there on these platforms. Why are we on these platforms? Because we know all of us are connected here. In LinkedIn, you know that, oh, this person works here. Supposingly you have some inquiries to make, you can directly connect with them on the messages. Facebook, you come to know, like I take care of the hospital Facebook. So I will put awareness things. I will put things like what has happened in the hospital. So people are aware of what's happening. Now what is the best part about digital media? The digital media is measurable. When I make an ad, I create an ad for a digital platform, I can keep my audience. Supposingly, if I'm doing an ad for a liver transplant, I can decide the location which has to be there, where I can see the liver transplant patients are there. Why? Because, maybe because of the obesity in that area, maybe because of alcoholic more in that area. So that's how you can target your audience. The age group. Why do you set an age group? Because a 7-year-old cannot take a decision in the family. Nowadays you see even 12-year-old on the social media, but they cannot take a decision in the family. So you will obviously target an age group of say 25 years to 65 years. So what I need to say is, simple thing, the advantages of digital media is, it is measurable. You know how many people have viewed your ad. You know how many people got engaged to your ad? You know how many people liked your ad? You know how many people responded to your ad? You can decide your audience, and it is extremely cost effective in comparison to ATL activities like I mentioned before, the print media, the TV, the radio. This is extremely cost effective. The third form of channel is the internal branding, and I love this part. Because any place, I mean most of us may be from hospitals, different organizations, but you all believe that your internal premises has to look good. They need to be talking about the brand. So when they talk about the brand, what is the most important thing in an internal branding? It is the tonality of the talk. What are you talking to your patients? Today we have different forms. We have things like banners, we have posters, we have standees. Now there are digital standees where you can put small videos, you can put so many things. So you like seeing it. When you enter a place, like for example, if I'm entering a skin clinic and I see all around, beautiful faces, a lady with a beautiful skin, I must have gone for a peel. But I would go inside and ask the doctor, can I do some laser? How is that laser going to affect my skin? So what happens? An internal branding gives you an additional client because he or she has seen it. So internal branding is very important. The fourth, and again an important, which we missed during the COVID times. The COVID times started with online activities. Then it was when the COVID was on the unlocking period, we had hybrid activities. But tell me, we all love the on-ground activities, isn't it? And that is one of the reasons we all are here. I'm sure everybody agrees to it.
Yes.
I can't hear. Yes. Oh wow, now I can hear. So you have community camps, you have corporate camps, you have in-house celebrations, you have award functions, you have walkathon, marathon, cyclathon. Like in the month of September, I did something called as a beach walkathon in Virat, in Arnala. We did it in awareness for, the World Heart Day, which was on the 29th of September. So these are kind of activities wherein you bring people together. When you bring people together, there is an awareness. And the people of like mind will come together. Now, this 50, 60 people sitting here, today what we are listening, we will go and share with other colleagues of ours. I mean, today what I heard about insurance, Dr. Gandhi, it was amazing. There are so many things that I could understand. Though I am a part of a hospital, I must have never gone for it because it was never required. I mean, Jyoti David is not called on the TPA counter. She's a communications head. But it was so knowledgeable. And we are definitely going to go and share it. Similarly, today what I'm talking here, what I'm sharing here, we will think about it. And that is where the similar minds come together during an on-ground activities. But is this all enough? No, it is not all enough. One by one, it is not enough. What you need to do is why, when, how, integrated marketing. Now, what is integrated marketing? I will give you a small example. While I was working with the IHH group, Global Hospital, Parle, Mumbai, Mr. C